Hello everyone, hope you've all had a good start to the year. Today I'm going to be talking about ulcerative colitis. This is the latest in the monthly series of talks on different pathologies that you're likely to encounter in medical school. So in much the same format as the previous lectures or talks that I've given, I'll very briefly give an introduction to ulcerative colitis, talk about some of the causes and symptoms that patients will have, talk about how you're going to investigate it, how you're going to treat and manage these patients, and then I'll give you a key takeaway at the end as well. Okay, so in terms of your studies so far at A-level, it's probably unlikely that you'll have encountered ulcerative colitis or even heard of it, but hopefully you'll have some understanding of the basic anatomy of the colon, which was in the last slide there, and also understand the functions of the large bowel, which is effectively to store poo, to move it along, and then passes into the rectum and the anus, where you then defecate. So understanding the basic anatomy of the colon and maybe understanding some of the functions of the colon are the kind of base level of knowledge for this talk. Okay, so what is ulcerative colitis, which I've shortened to UC there at the top. So what is it effectively? So what it is it's a long-term autoimmune condition. So because it's autoimmune, that effectively means your immune system recognizes some of the cells in your own body as foreign and starts to attack them, and that then causes some of the symptoms and feeling unwell. So it's the immune system targeting one's own cells. So it's an autoimmune condition where the colon and rectum become inflamed. And indeed, ulcerative colitis is very similar to another condition that you might have heard of called Crohn's disease. So ulcerative colitis and Crohn's disease are both in the same family of diseases called inflammatory bowel diseases. So they are diseases of the bowel, and they are diseases where the bowel effectively becomes inflamed. Okay, so ulcerative colitis is autoimmune and it involves the colon and the rectum becoming inflamed. And I've also mentioned there in this slide some of the risk factors for ulcerative colitis. You'll tend to find it more commonly in younger patients. People present with it at a younger age rather than much later in life. Ethnicity can also determine the likelihood of getting it, as well as family history. If you've got a family history where, for example, one of your parents had ulcerative colitis, it's much more likely that you'll get it compared to someone who doesn't have that family history. Okay, so someone comes in with ulcerative colitis, which, as we've mentioned, is an inflammatory bowel disease. What kind of symptoms are they likely to be presenting with? So some of the key symptoms are diarrhea, rectal bleeding, abdominal and rectal pain. Hopefully this should make some kind of sense. It's effectively a disease where your bowel is becoming inflamed, it's becoming red, it's becoming swollen. Because it's becoming inflamed, it's very plausible that you might have some blood in that area. You're going to feel pain in the area. The amount of poo you're going to pass is going to vary. You might be passing it more frequently, more watery. So those are some of the key symptoms that you're likely to find in ulcerative colitis. But the symptoms aren't just limited to the stomach area or to your bowels. You're also going to have what we call systemic symptoms. And what that means is you're going to have symptoms that affect your whole body. So for example, you might feel fatigue, you might have a fever. Very often people with ulcerative colitis can get things like pyoderma gangrenosum. They can get changes to their skin where it becomes inflamed, it becomes red, it becomes painful. So these are some of the key symptoms that people with ulcerative colitis will present with. So as you can see, it really affects it will obviously cause them pain, but it really affects many aspects of their body and can affect their life in very significant ways. Okay, so someone comes in with some of these symptoms. You're thinking, wow, this person might have ulcerative colitis, or they might have Crohn's, or they might have there's something inflammatory happening here to the bowel. How would you go about investigating this? How would you go about investigating these patients? So one thing you do is you do blood tests. And blood tests can show you many different things. It can show you anemia, it can show you infection, etc. But one thing it can also show you is inflammation. And there is this marker called CRP, C-reactive protein. and that is a marker of inflammation. So if you see CRP very raised when you do the blood test, that indicates that there is an inflammatory process going on, and that gives further support to the idea that it might well be ulcerative colitis. You can also do a special test called a colonoscopy, where there is a long flexible tube that's inserted into your rectum to kind of to visualize your rectum, your colon. And what that will show again is the inflammation, maybe some ulcers. It gives you a better picture of what's happening in your bowel. And you can also do a biopsy, so you can take some cells from that area. You can take some cells from the colon and you can analyze them. And what that can show is something like crypt abscesses, which is very commonly found in ulcerative colitis. So you do these blood tests, you do this kind of special imaging of the colon, and then you can also sample some of the cells and analyze them in the lab. Okay, so suppose you've done these. The patients come in, they've got all these symptoms. You think it's ulcerative colitis. You do the relevant investigations. The investigations support your presumption or your suspicion that it's ulcerative colitis. How would you treat these patients? Now, there's many different aspects to the treatment depending on how severe the symptoms are, how long it's been going on, how unwell the patient is, etc. But some of the key aspects of the treatment are mentioned on this slide. So one thing you can give are aminosalicylates, also known as 5-ASAs. And what these help to do is reduce the redness, reduce the swelling, curb that inflammation. Another thing you can do, particularly if the patient is experiencing a severe flare, and there is in fact a scoring system for ulcerative colitis. I'm not going to go into it now. You'll definitely encounter it in medical school. It's called the True Love and Whips Severity Scale, and it's a scoring tool to effectively determine how severe a flare-up someone is having of their ulcerative colitis. But if it's a more severe flare and the patient's feeling really unwell and they're passing a lot of bloody poo, and they have a fever and their heart's beating really fast, so they're very unwell, you can give them steroids. And what that helps to do, again, is to reduce the kind of immune attack or immune-led inflammation of the colon. Again, in more severe cases or in more long-standing cases, you can consider giving people immunosuppressant medication. I've mentioned a couple there on this slide: cyclosporin, infliximab. And what immunosuppressants do, as the name suggests, is it reduces or curbs or diminishes the immune response. And because, as I mentioned at the start, ulcerative colitis is an autoimmune condition, by curbing the immune system, you'd hopefully help alleviate some of these symptoms that patients are having. But if patients continue to be really unwell and none of this medication helps, you can consider surgery. And the surgery might involve removing the entirety of the colon. So that you can also do in more severe cases where medical treatment doesn't help these patients. Okay, so what is the key takeaway from this case? I would say I've already given some of the key takeaways in previous cases, but I would say from this specific case, the key takeaway is that treatment can really be multifaceted. We saw that on the last slide. You'd give medication, you give certain medication if it's a less severe, if it's a milder presentation. If it's more severe, you might consider other medication. If it's really, really severe and it's long-standing and chronic, you might have to consider surgical intervention. You'd want to give these patients lifestyle advice as well, good dietary advice, stop smoking, etc. So really, treatment is multifaceted. There's a lot of different things you need to consider to help the patient and to help improve their symptoms. So I would say that's the key takeaway from this case. And that concludes this month's talk. Hopefully you've learned a little bit about ulcerative colitis. It is a very common condition on gastrointestinal wards. So when you do your placements, I'm absolutely sure you'll encounter it and continue to build your knowledge of this condition. But hopefully this has been an interesting and helpful introduction to it, and I look forward to presenting again next month. Thank you.